Good evening, everyone. We'll just let everyone come in. How are you, Ibs?
Yeah, not too bad, thank you. Not too bad. Made it in time from work. Was working till 6 o'clock today, so
Oh, you did well then.
I did well, absolutely. Yeah, not much notes to do, which was good.
Yeah. Is it sunny in Brighton?
Always sunny in Brighton, even when it's
Yeah.
yeah.
I wish I could say that about where I live. It
The
has been
complete
sunny in
opposite.
Scotland today, though, so we're doing okay. We're
Yeah.
fine. And I think it's to be nice for the weekend, so we'll cross our fingers.
Fingers crossed, yeah.
Let a few more people get in. Welcome, everyone. There's people coming in. We'll just give it a little minute or so, and then we will start. Just to let you know that the chat is open, should be open, and also the Q&A box as well. So feel free, if you want to put any kind of more general comments in, you can pop those in the chat. If you want to ask a question for Ibs to answer at the end, then you can put that in the Q&A box. So we'll make a little start. There's lots of people here now. So delighted to host this Ikigai Oral Hygiene Community webinar this evening with Ibrahim, or Ibs, or Ibi, whatever you like to call. You answer to everything, don't you, Ibs? So Ibrahim has been a dental therapist since 2019. He's working across a couple of practices in Brighton, utilising his full scope of practice. He will introduce himself fully later on. Just to mention that we're going to do the CPD certificates a little bit differently today. So we're going to trial a new system. So towards the end of the webinar, Ibs will share a QR code that you can scan. You should be able to fill out a form online and it will automatically send you your CPD certificate. So rather than the usual system of us emailing it out to you, I will also put a direct link to that into the chat. So anyone who can't scan the QR code, maybe because they're on their phone, you'll be able to click that link. I would suggest if you struggle with that, just to take a screenshot maybe of the QR code and you'll be able to do that later. Any kind of issues, then you'll be able to go on the NSK website. This will be uploaded as usual within around 7 days or so. So if you give us around 7 days just to get the video formatted and onto the website, and you'll be able to go on there if you have any issues and get your CPD certificate that way. Without further ado, though, I will pass over to you, Ibs. You can share your screen and we'll let you get going.
Very much. Perfect. Okay, so good evening, everyone. Thank you very much for joining me this evening to discuss composite care and the key to longevity and effectiveness. So a little bit about myself. I know Lauren gave a brief introduction, but I graduated from the Eastman Dental Hospital back in 2019, and I work across private practices in Brighton now, but previously worked in London as well, carrying out my full scope. I have a special interest and quite passionate about cosmetic dentistry, as well as paediatric dentistry. And I'm very fortunate to work across 2 practices in Brighton, where I'm able to do those things. In my spare time, because I don't have a very exciting life, it's still all dentistry. So I'm part of the amazing Ikigai team as a clinical educator, also a Dentinal Tubules educator. And I am now part of the executive council with the BADT as well. Okay, so what is our aim for today's presentation? Well, we want to highlight the essential care and maintenance needed for composite bonding to ensure its longevity and effectiveness. We will cover practical tips for maintaining composite bonding, including proper brushing techniques, foods to avoid, the importance of regular dental checkups, and how to manage composite bonding as DCPs during our routine hygiene visits. The presentation intends to provide delegates with a deeper understanding of how to maintain and enhance the professional practice. After this presentation, you should have a clear understanding of how to take care of composite bonding for a lasting, beautiful smile. And here are our objectives. Understand the basics of composite bonding. So we're going to learn what composite bonding is and how it is used to improve the appearance of teeth. We identify proper care techniques, understand the key oral hygiene advice and its importance for composite bonding patients, recognize foods and habits to avoid, learn which foods and habits can damage or discolor composite bonding and how to avoid them, and learn how to manage composite during oral health examinations and hygiene visits, and discover how to care for your patients with bonding during oral health examinations and hygiene visits. Okay, so what is composite resin? Composite resin is a tooth-colored material used in dentistry to restore the function and appearance of decayed or damaged teeth. It's made from a mixture of plastic and fine glass particles, which can be sculpted to match the natural contours of the teeth and polished to achieve smooth, aesthetically pleasing smile. Pleasing finish, should I say, sorry. And composite has evolved significantly, and we'll go into details of that in just a moment as well. They're favoured for their versatility and ability to bond directly onto tooth structures. They provide strong, durable restorations that can be used for fillings, veneers, and composite bonding. And now with amalgam phasing out as well, we're going to be seeing loads more composite within our patient's mouth, whether it's to restore function, restore cavities, or for cosmetic reasons. So the components: matrix, filler, coupling agent, initiators and accelerators, as well as pigments. The key component in composites that we're going to focus on for a little while is the filler particles. Okay, so the durability of composite resin mainly is related to the filler particles that's in there, and that's either the amount of filler that's in there or the filler size. And with smaller particles, they will give a really nice polish, and sometimes you don't even need to polish them, honestly. You just rinse them with a 3-in-1 tip and you'll get a really nice finish, which is great aesthetically. And with the larger particles, it's a lot harder to polish. You get a much rougher surface. Then you've got the low filler strength, low filler content. So if there's not as much filler in there, the strength of the composite with occlusal forces is not ideal. So it's more prone to chips and breakages. And then obviously, if there's an increased filler content, the surface hardness and compressive strength increases. Now, it's quite important to understand this because there's so many different types of composites on the market nowadays, and we never know what's in the patient's mouth unless we place them ourselves. But having an understanding of what type of material is in there makes a big, big difference. So the structure, let's go back, okay, to the 1960s, well before my time. But we used to have macro fill composites, which were about 10 to 50 micromillimeters. So they had very large filler particles, as we could see on the screen there, which made them really, really durable and strong, but they were not great to polish and didn't look great aesthetically, very, very rough. And then we move on to the mid-fill, where the size of the filler particles become a lot smaller. And slowly, as we get into the 80s, we move on to the microfill composite phase, where you can see there's a significant difference. So it's 0.01 to 0.1 micromillimeters. And that means that the filler particles are a lot smaller, resulting in a smoother finish, so you get a much better finish with the composites. But then we found that although we were at that stage, they weren't as strong as we wanted them to be. So that's when hybrids and micro hybrids in the 90s, moving on to the nanofill, and finally we're at this nano hybrid stage with composite materials. So you could see, you know, over the last sort of 30 years in that gap there, composite has evolved significantly. And I think it's an area that's going to continue to evolve and change throughout. But the nano hybrid composites have now got a really nice balance with loads of filler particles, different sizes, to get that really nice combination of a nice polish, a nice shine on your composites, but also quite durable. So, you know, very popular composites in the markets. If we look at some examples, you've got Venus Pearl, you've got IPS Empress by Ivoclar, both very good high-end composites, both provide very nice finishes. But if you look at the studies, you'll see that the Venus Pearl is a lot stronger. But the Empress, I use Empress in one of my practices, Venus in the other, and I could see the difference. When I use the Empress, I hardly need to touch the tooth with a soft flex. It gives such a great polish, but they're more prone to chipping. So being case selective, you know, if you're worried about sort of occlusal trauma or your patient's habits, you know, it's very important to pick the right composite material and just have an understanding. If you're unsure, you could always contact the reps and they'll give you a really nice breakdown of how their composites are made and why they're made that way. Okay, so special shout out to Tracy Dool. She sent me this lovely study on sustainability when she heard I was doing this webinar and brought this to my attention. I mean, our carbon footprint in dentistry is not ideal. And we're getting better, you know, with amalgams phasing out in Europe earlier in the year and eventually phasing out here as well. We're getting there, but it was just brought to my attention that although composite is loads better than amalgam, it's still not great for the environment. So she sent me this study and I thought it would be good to just very briefly go over this. I don't want to go too crazy with the science, but yeah, so we found, looking at this study, which was carried out in 2022, the key points that we could take from this was that the chemical compounds present in resin bonded composites may act as pollutants. So the degradation process of composites and its environmental consequences, the methods for detecting and quantifying monomer elution and microparticles. So elution of monomers refers to the process where unreacted monomers from materials such as composites are released to the surrounding environment. And this could be when they come in contact with solvents or liquids, when they fracture, when they chip, which composites do, as we know, they leak out over time. And obviously we need to consider the waste as well, you know, when we're just disposing of these composites. So, you know, in comparison with dental amalgam, it is a lot better, but there is still some concern over resin bonded composites. So I think this is where we were talking about the changes earlier. I think some companies will make some more changes to composites to come just to make them more sustainable in the future. So they do have pollution potential. They contain monomers and microparticles that can leach out into the environment and potentially affect our ecosystem. The waste management strategies, researchers suggest minimizing the waste and improving material design to reduce pollution. So you'll see some composites come in capsules, some composites come in compules and syringes. So being very mindful of what you use. And obviously the carbon footprint of dentistry contributes significantly to the carbon emissions as well, with travel and procurement being major factors. So what can we do as dental professionals? Well, ensure that there is a minimum composite waste in surgery. If you're doing a very small composite, are you better off using the syringe where you could, you know, take as much composite as you can that you need, instead of using a capsule and you use a very small amount and then have to dispose of the capsule. Well-maintained composites to ensure longevity and minimize leakage, which we're going to get into very, very shortly. And of course, be aware of this. It was brought to my attention recently, and I think we all need to be a little bit more aware of what our carbon footprint is like, especially within dentistry. So watch this space. I'm confident there's going to be loads of changes coming from what I hear. And I think that we need to be up to date with that and be aware of that, because more and more patients. I'm based in Brighton, and you know, we were the Green Party for a very long time. I've got very conscious patients that are always asking about sustainability, bamboo toothbrushes and bamboo teeth pieces, etc. So it's good to have this information and just be aware of what the materials we're using. Okay, so let's get into the composite boom. Okay, so the composite boom, as we call it, happened in around 2019, 2020. And I don't know if you guys remember, but that was the year that we had COVID. And we think that had a very, very big part to play. And I'm sure you all had those sort of family Zoom quiz nights where we were all on camera, which were great at first, and then it just got a bit like, oh, another one, and you knew the answers to all the questions. But patients and people out there were becoming a lot more aware and conscious of their smile, because everything was moving on to online platforms and they could see their self. and what their smile looked like and their teeth looked like. You know, cosmetically, the composite industry was there going back to 2016, 2017. It was still quite popular, but I think it wasn't until 2019, 2020 where the composite boom happened, and people were a lot more aware and wanted to improve their smile. And that brings us on to the great battle. Okay, so this is my patient on the left-hand side there. Katie is also a patient at our practice. I don't personally treat her, but I have had long discussions about her teeth with her, and I treat Harvey and a couple of the kids as well. She's completely aware of what she's done before we get into that, but this is the great battle that we're always fighting. You know, I'm a dental therapist, so obviously I don't do crowns or any porcelain or any indirect work, but we always try to persuade patients to think about what they're doing. A lot of the time, you know, patients come back and see me after I've advised them not to go Turkey, saying, you know, I've gone Turkey, I've got my veneers done. They're not even aware that they've got crown in their mouth. And, you know, unfortunately, that's the pegs that they can see. But in a way, what Katie did here worked in our favor. And I had so many patients come in to see me saying, I don't want my teeth shaved down, but I want to improve my smile. So they are aware of it. There are some people that don't care and they just want that instant result, and they're attracted by the nice weather and the flights and the hotels and everything else and how that whole system runs. They're attracted by that. They're attracted by how quick and easy it is to get a smile. But if we compare the lovely Saskia's smile here to Katie's smile, we can see there's not much difference. Okay, it's a very Hollywood, large, white block teeth, but that's what they wanted. And that's, you know, it's exactly the same thing, but we've not had to shave Andy's teeth into pegs. So I'm very passionate about trying to get patients to transition. You know, eventually they might want to go to porcelain workflows, but in the UK, you know, there's a lot of minimal prep. Now there's even no prep veneers happening. So we've made such great progress, but the great battle is something that we're always going to come across. But composite bonding definitely had a bit of a boost with Katie's picture all over the front page of newspapers and social media. So it was a bit of help. I don't think she'd done it intentionally, to be honest, but it definitely helped us in a way. So whose responsibility is it to maintain these composites? Is it the clinician, the dentist, or the dental therapist that placed it? Is it the patients, or is it the dental therapist or dental hygienist that's maintaining these on a regular basis with some oral hygiene visits? Well, obviously the answer is we're all responsible. So I thought it would be a really good way to break down how we're all responsible and what we can do. So this is Saskia's smile that we saw earlier, just on the right-hand side there. She was mainly concerned about the colour of her teeth. So obviously we recommended teeth whitening. Then she said that she doesn't like the fact that her canine teeth are pointing inwards, and she didn't want to go down the Invisalign route. So we looked at composite bonding, did a few trial runs, and we got some really nice results, and she's really happy, which makes me really happy. What can we do as clinicians to ensure that our composites are going to last as long as possible and they could be easily maintained by the patient? Well, we need to make sure first and foremost that the margins of the composites, if we are placing them as composite veneers and not edge bonding, but if we're placing them as composite veneers like this image here, the margins that reach the gingiva, we need to make sure they're really nice and smooth. Ideally 1 millimeter just below the gums. It's composite and gums are just a no-go. Okay, so our gingiva just doesn't get along with composite, doesn't like it, needs natural tooth surface there. So if you can leave that 1 millimeter space, if you're placing these, it's great. If not, then really make sure that those margins are nice and smooth. Otherwise, it would just constantly irritate the gums, lead to further recession and more problems. So margins is a big one. Interproximal contact points, you want to make sure you've got really nice contact points in between the teeth. They're all nice and smooth. They're not rough to attract staining around those areas. Patient could get floss in between there, TPs or easy picks. but you want to make sure that the contact points are really nice. And then, of course, occlusion is a big one, including lateral guidance. So that's how our teeth are biting, and then how our lower jaw moves side to side. So ideally, you want your patients to guide lower jaw movements using the canine teeth. The canine teeth are the longest teeth in our mouth, so they're really good at taking those type of forces side to side when we're chewing. So you want your patient to have that canine guidance, and if they don't, you might be able to implement that by adding some composite behind the tooth surface, but always get input from the dentistry. If you're starting to do a few things with occlusion, always get an input from a dentist if you're not confident in doing so. But you know, I've been doing these composite cases for coming up to 6 years now, and I still to this day get a dentist involved when I'm changing occlusion, especially. But you want to make sure that the way the teeth are biting are not leading to any breakages. So, for example, we sometimes see patients coming in with really flat canines and they want some composite bonding. Well, why are those canines flat? And now they're putting so much more pressure on other areas, which we call group function, when they're grinding along their teeth, and that force is just going along there. It's not ideal, because when their teeth are flat and they're biting down, they're very likely to chip these composites on the front teeth as well. So take occlusion into there. Another top tip would be your final cure with glycine. It's so important. So once you've placed your composites, make sure that you pop your glycine on there. Composite is super porous the first 2 weeks, so they're very likely to stain. 9 times out of 10, your patients would have had some whitening before the composite bonding. So you've already told them to avoid red wine, teas, coffees, and everything else during their whitening process. They come in, they get their composites placed, and then they go away thinking, well, my teeth are nice and white now, it's absolutely fine, my treatment is done. And they go away and they binge on their red wines, their teas, their coffees, and all the rest of it, and unfortunately come back with loads of staining. So that's where your glycine comes into play. Placing your glycine really, really helps with that staining side of things and allows the composite to fully set. And on top of that, always with all my patients, a post-op final polish. 2 weeks minimum. I normally get my patient back within 3 to 4 weeks to give everything a really nice polish. Leave the composite a little bit thicker just around the front there, because I know they're going to stain in those first 2 weeks, and it allows me to polish it down a little more in order to get that really nice fine finish there. Diet advice. So what advice are we giving our patients? Are you giving them this advice on the appointment after you place them? Because really you should be doing this at the consultation appointment when you first meet the patient if you're placing these composites. Maintenance advice. This goes right down to your regular hygiene visits, to the electric toothbrush, manual toothbrush, interdental tools, the toothpaste that they're using, and of course your regular examinations with their dentist and or dental therapist, as well as a review. I like to review my patients yearly with the composites just to see how things are looking and ensure that they're not chipping, breaking, and they're looking after them. So this is another one of my patients who came to see me and said that he wanted composite bonding. And I do this with all my patients because they're all a very young demographic. And I always say, well, why don't we do a little bit of whitening? And they say, no, I don't want that. I don't like the way my teeth look. And I say, well, why don't we do some Invisalign, you know, and get your teeth? No, don't want that. I want really big, white, flat teeth. Because they're all involved with social media nowadays, and they're just very conscious, and that's what they see and that's what they want. So I'm very happy to provide that for them as long as they have a lot of understanding. Joel came to see me. He was smoking, he was vaping, so we were like, this isn't going to work. It's not ideal. You're going to stain these composites and they're going to last very long, and you're not going to get that big white smile that you want that's going to last long enough. So we saw him over a few visits with oral hygiene appointments. We did some teeth whitening and he stopped smoking and vaping. And eventually we managed to achieve that lovely smile on the right-hand side there for him. So the patients need to be aware of their oral hygiene routine and how important it is. Even though your composites are polished and they're really nice and smooth, and it may not be covering the whole tooth surface, you know, we might be doing a little bit of composite edge bonding. You still need to be aware that we're adding something onto the tooth. So if your patient has fair oral hygiene, fair's not going to cut it. Be really strict with them. They need to have really good oral hygiene, ideally an electric toothbrush with a pressure sensor, cleaning in between their teeth daily with floss or easy picks, TPs, whatever it is you recommend, depending on the spaces there. And then also discuss with, this is where I was talking earlier about occlusion, but discuss about protecting these composites with possibly a retainer with your dentist. Advise your dentist to have a look and assess and see if they'd recommend the retainer to wear in the evenings to avoid this patient. You know, are they clenching their teeth at night? Are they grinding their teeth at night? If you're changing the occlusion, then a retainer might be a good idea. And if you are going to require a retainer and dentist says it's a must, then are you confident that your patient's going to wear this? Because the last thing you want to do, time is valuable. The last thing you want to do is place these composites, and then you see this patient every other week and they're constantly chipping these composites. And believe me, I learned the hard way. Didn't screen my patient very well, didn't understand the habits that they had, which we'll get onto in a moment. And I spent so much of my clinical time repairing these composites constantly because I didn't do very good screening and patients didn't understand the maintenance it took. So there was a breakdown in communication somewhere. Diet. So in brackets there, I've got GMPB. I always like to say to my patients, when it comes to composites and staining, if it stains your glass, your mug, your plate, or your bowl, it's very likely to stain your teeth. Okay, so that's a really good thing that I always say to my patients. I always give them an example, you know, a glass of wine, a mug of tea, a plate of sort of heavy tomato-based pastas, or a bowl of curry with loads of turmeric in it, whatever it might be. But these are things that are very likely to cause some staining. Obviously, once patients have some composites, it doesn't mean that they need to avoid these foods at all times, but brushing 30 minutes after eating helps. Follow in with some water straight after, and regular sips of water throughout the day really helps promote saliva and wash away some of the staining as well. So habits, opening bottles, packets with teeth, these are all things that they need to forget about. We are bonding composite, we're gluing it onto the tooth surface. Any type of force will cause them to chip and break, and even be very careful with, you know, very crunchy baguettes, maybe bite a little bit to the side. Diet advice, like I said, you want to avoid any hard, crunchy foods, biting into these hard foods, biting into apples. Yeah, we do trust the bond, and as long as you follow protocols, you know, things should be absolutely fine. But the force that people use sometimes to bite into these hard foods would definitely cause chips and breakages. So you've got to tell them that if you want to commit to this, you are going to need to bite and chew on your back teeth and avoid hard foods in your front teeth. Maintenance advice, toothpaste we're going to go into in just a moment in a little more detail. But regular hygiene visits, obviously, is the patient aware that once they get this, they're going to need to see the hygienist regularly, or they're irregular attender at the moment, and regular examinations and reviews of composites as normal. Just because you've got these composites on, patients, believe me, they think, oh yeah, my teeth are protected underneath. They're not. We still need to do our routine examinations to ensure, and do the patients understand that. Okay. So I always give a maintenance form at my consultation appointment. So at my consultation appointment, I tend to give patients 2 lots of treatment plans. One treatment plan is for the cosmetic stuff that they're asking for. Another treatment plan is for all the health needs, hygiene visits, stabilizing gum health, any fillings they may need, etc. And then I also give them a maintenance form with some instructions. And this is what my one looks like. But it basically gives them an idea when they read this of the responsibility they have to look after the composites that they have. So it's really, really important that patients have an understanding. They don't need to sign it then, but on the day that I'm placing the composites, I'll ask them to sign a consent form and then also a separate maintenance form, just so I know that they understood the advice that I've given. And it's all the things we just spoke about. You know, the importance of using an electric toothbrush and cleaning in between your teeth, the importance of avoiding teeth that might stain your teeth, avoiding food, sorry, that might stain your teeth, as well as mouthwashes like Corsadil, etc. So I put all that on there, all the habits, biting, etc. So I feel confident that my patient understands everything that is required from them. Okay, so maintenance appointments. This is another one of my patients where, you know, composites ain't always an amazing smile makeover. This lovely lady come to see me and said that she wanted her diastema closed. She didn't want any whitening whatsoever. She didn't want the shape of her teeth to change in any way for us to add to the length of the teeth. She just wanted the space between her teeth to be closed. So beforehand, she would have got a grey TP in there. She's not going to get that anymore since we placed those composites on there. She's now, you need to then go in and talk to patients about what to use to clean in between their teeth. And I know it sounds silly and obvious to us, but we need to ensure that the patients are looking after these composites as well as they can. Toothpaste. Okay, so this is the relative dentine abrasion chart that I've created here. Of all the main toothpaste out there, I know there's always new toothpaste brands coming. I can't keep up at the moment, but the main toothpaste brands out there and how abrasive they are to dentine, which gives us an indication of how abrasive things are to composites as well. If you imagine that toothbrush and a water has an RDA value of 4, okay? So I've color-coded everything. So we could see that, for example, Arm & Hammer, combine the words there, Arm & Hammer Advanced White, which to me, the name sounds like a very abrasive toothpaste, actually has an RDA value of 42. So it's quite low. And then you've got your Colgate Total. Now these values are, I've cross-referenced them and I've checked them from other sort of studies that have been carried out. But keep in mind that everything is changing constantly. I know Oral-B recently have completely changed all their formulas on their toothpaste. So they may vary a little. They're not the exact number, but it gives you an idea. If you look at the color codes, Colgate Total is in the medium. And then if you go dark into the orange and the dark red there, you've got Oral-B whitening, Crest Extra whitening, Colgate 2-in-1 whitening is very high, very abrasive. And patients are buying these because they think that they're whitening their teeth, but actually they're brushing away some of their enamel and showing more of a yellow tinge on their teeth. So it's very important to be aware of this when you're asking patients, you use an electric or a manual toothbrush. What do you use to clean in between your teeth? What toothpaste are you using right now? It's good to know. It's definitely very, very important to know and advise patients to use. I always say to my patients, whether they have sensitivity or not, I advise you to use some sensitive toothpaste because I know that that's not going to be very abrasive on their teeth. So maintenance appointments. What are we going to do for these patients that have composite edge bonding or composite veneers on their teeth? Are we going to use an ultrasonic scaler and polish? Are we going to use some air polish therapies? Are we going to be using some polishing burrs to polish the composites? Well, a combination of all three, in my opinion. Very case dependent. You know, you may decide that you just need to do an air polish. You may stick to your traditional ultrasonic scale and polish with some polishing paste. But again, the abrasiveness of the polishing paste is quite important. Make sure that it is suitable for composite materials or crowns or veneers, whatever it might be, because some of them are quite coarse and are only suitable for enamel, maybe should be used for stubborn stains. So be cautious of the type of polishing paste that you're using. Okay, so if we talk about polishing burrs and paste, there's loads of burrs out there, and if it's something that you've not done before, I'll give you my top tips of the safest ones to use to avoid you causing any harm to the composites. But I definitely recommend, if there is a little bit of staining on composites, you can definitely offer polishing these composites, buffering them up slightly. So there are specific composite polishing pastes like Enamelize, and also Lucida is a very good one that I use, which we'll go into in just a moment. There's some polishing strips, and these other burrs. So if we start with the Softlex disc, they come in normally 3 or 4 different levels. So the darker the soft lex usually means the more coarse it is, and the lighter the soft lex, the softer and kinder it is. So my advice will be completely, if you're just starting up on polishing composites, completely ignore the top two, okay? I place composites all day, every day, and I never use the really coarse soft lex, because as soon as you touch that composite, it eats away at it. It takes away anything that's there. So if there's beautiful anatomy in that composite, you're just going to wash that away. You're going to change and alter the size, the depth, and the shape of that tooth completely. So completely ignore the top two is my advice. Then you've got the enhanced diamond encrusted polishing burrs, which come in that wheel, the pointed flame type, and the cup. Again, when these start to heat up, they actually do melt away some of the composites. So if you're just starting up, I'll avoid those. I'll stick to the light orange and the light yellow soft flex discs. And then you've got some polishing wheels. These come in loads of different brands, like the soft flex as well. So with the polishing wheels, they normally come in two different levels. One of them, which is normally the darker one, but please check with the manufacturer. So you either get some ASAP polishing ones, which are these ones here, or you could get some EV rotary ones, which is a pink and a grey. So depending on which one, please check. One will say coarse, one will say fine, or one will say rough, one will say soft. Always stick to the softer, the kinder ones, because you're not going to do any harm. But these polishing wheels are encrusted with diamonds, and they work brilliantly. They're so easy to use, and they give composites an instant shine. So I'm a really, really big fan of those. Polishing strips, again, when you start getting some more confidence, if it's something that you've not done before, you could use some really light polishing strips for the contacts to remove some stain very lightly. But be careful if you're using some coarse polishing strips. Oh, what's going on with me? I've done a lot of talking today at work. Some coarse polishing strips, you will start opening up contacts, which is not ideal. Patients won't thank you for that with all the food trapping they're going to get. So try to avoid using those as well. So let's go over what will be a good way to start using these. So this is my little setup for a nice polishing. This is how I got into composite bonding. I was really interested in it because I really liked being quiet for a long period of time and just focusing on something. Don't know if you guys could see all my Lego behind me as well, but I'm a bit of a geek that way. So composites amazed me straight away, especially when it got to smile makeovers. I really enjoyed that work in progress. Not so much the patient's expectations, but I think that's a whole different presentation. So this is what my setup will look like if a patient is coming in for a review appointment for me to see them, or a maintenance appointment for me to polish their teeth, and they've got some composites on there. This is what my setup will look like. So we've got the mandrel that will be for the soft flex discs attachment. Then we've got the Lucida polishing kit, which is that lovely star fin there. And it comes with a little attachment that goes onto, and some Lucida polishing paste, which works really well. This is the Style Italiano, guys. And if any of you guys know about Style Italiano, they're very good. So I use that. You could use some enhanced polishing burrs as well, the wheels or the flame, whatever you prefer. But again, be very careful. And then I've got the Eve rotary polishing wheels there. I'm going to completely skip the pink one because I know that that's going to change the anatomy and take away some composites, and just use the grey one, unless I want to change the composites, which if it's someone else's work, I don't advise you do at all. Okay, so this is my lovely nurse, and this is how I got into composites. I persuaded all my nurses. Well, it didn't take much persuasion, to be honest. As soon as I did the composite bonding course, they all wanted composite bonding. So this is lovely Molly, and she's very kindly volunteered for me to get these videos on how we polish these teeth. So the key things to remember is when you're using these soft flex discs, so whether it's the light orange or the light yellow, remember we don't want to use the darker ones. Even though I'm confident that I'm not going to remove any composite away from her teeth, what I do want to do is still follow those natural anatomy lines. It's just a very good habit to have. You want to follow those anatomy lines all the time when you're buffering composites. It's how the light bounces off those lines that give a really nice look. So you place the soft flex disc over the tooth surface, flat facing, and very gently on about 8,000 RPM on your handpiece. If you could adjust the speed of your handpiece, that's great. If not, very similar to what you would use, speed to what you would use to polish a teeth with some polishing paste. Just have that control over the foot pedal and very gently start buffering these composites up. So start with the darker color, work your way towards the yellow and follow those anatomy lines, and you'll naturally start to see the tooth starting to shine very, very slightly around those areas. Now, there's no correct order of doing this, but this is my order. I'm not saying you need to do it in this way. It works well for me, and I'll tell you why in just a moment. But then I move on to the Lucida polishing kit, and I use the Lucida polishing paste, as you can see, just on the edge of my glove. Again, I'm not concerned about me rubbing off those anatomy lines, but I just like to follow them because it's a nice habit to have. So I start polishing the tooth surfaces with the composite. Again, you could see here with the soft lex, we use it flat facing. With this Lucida polishing staffing, we use the edges of the wheel. Okay, that's where you're going to get that really nice shine coming through as those staffings are rubbing off with that Lucida polishing paste. You get a really nice finish, and you could use this across all composite materials. Okay, on all surfaces. And finally, I'll finish off with the polishing wheel. I dip it in some water so it doesn't overheat, because I'll take my time with this one, because this is the one that gives that magic pop, I like to say. It really makes it shine right at the end. You get a really nice reflection. And again, you use the edge of the wheel along all surfaces here. And don't be, too concerned about the anatomy lines, but try follow them as best as you can. I pop an Optrugate in just so I've got a really nice clear view, as you can see as well. And that gives a really nice reflection. You can see it just naturally gives a shine. And also, the paste that we used earlier always gets stuck in between the teeth. So it's really nice for you to be able to just dip it in some water and just wash that away for the patient as well. Because then otherwise, when you show them the nice shiny composites, they're too busy looking really close in the mirror and picking out some of the polishing paste. So this is a really good technique to just follow it. That order tends to give you, and you don't need to spend a very long time on these teeth, okay? Just a natural buffer. As long as the patients are very good with their appointments and they're very good at looking after them, you don't need to spend a very long time. If you have any stubborn stains in the composite materials that you can't remove, and you've not placed the composites yourself, then advise them to go back to the person that placed the composites, or get an opinion from your dentist and see if there's anything that they can do. But ideally, you want to just focus on your normal maintenance appointments and not really interfere with other clinicians' work. You don't want to start polishing things out and changing anatomy of teeth, because that could lead to a whole different wormhole. And we're speaking about responsibility, but then you're picking up someone else's responsibility, which is not fun. Okay, so that's how we polish using our polishing burrs. Do they all give the same result? Pretty much. This is a really good study. That was back in 2019, I think it was. And it's basically a magnification of 4 different type of burrs after the cleanup. So what they did is they placed some composite on the teeth, and then they just polished that composite down, and then took a really 200 times magnification of the enamel to see how much enamel they're damaging. So it's come out that the one gloss system, the stain buster, which was very similar to the, let me just go back, very similar to the enhanced burrs just along here, the second one's in. So very similar to those, the stain buster burrs. And that's exactly what they found. They found that they were the best. They created the smoothest surface and didn't harm and disrupt the enamel as much. And as you could imagine, the coarse soft lex discs and wheels were the ones that disrupted. But overall, there wasn't too much in it, okay? So would I like to use a combination of all those things? You might just be comfortable using one, and that's absolutely fine. There's not a huge difference in what you choose and what you're comfortable with. It's what works for you. And there might be some burrs that I didn't mention there, but I just find that that system works really well for me. And so it's what works for you, but overall, there's not a huge difference. Now, if you're borrowing burrs or discs from another surgery and you're not sure of how it's used or how coarse it is, please just double check with someone that does know, get in contact with the reps. Nowadays, we've got the power of AI, use it. Have a look on the ordering website. They tend to give you quite a bit of information as well. But just use something that you're comfortable using is the main thing. So air polishers, okay. I work across 2 practices, as mentioned before. In one of my practices, I use the NSK Varios. In the other practice, I use the EMS. And I'm very happy with both of those systems. But just to summarize how air polish works, the air pressure controls the flow of the powder and the water pressure controls the flow of the water. And then you get a controlled spray, which propels powder particles. And you get a nice effective stream which removes any biofilm and or staining. Now remember, the powder comes out from one part of the handpiece and the water comes out from another. So they actually meet at some point. So depending on what air polishing system you're using, you need to be aware of when they meet, because that's the distance you want to keep away from the tooth surface. So which powder do I use? There's so many air polishing systems out there at the moment, so many different types of powder. The Supra powder has higher abrasiveness, and you could use those for pre-fissure sealants, super gingival stain removal, only on enamels, not on crowns or composites. And if you do use it on orthodontic appliances, the really abrasive ones, you could remove the colour of the bands actually. So check to see what type of powder you're using. You want to stick with the sub powders, okay, when you're using composites, polishing composites. They're great for crowns, bridges, implants, perio treatment. You could use them subgingivally as well. And they're the ones that are very safe to use on composite materials as well. So the ones that I'm aware of, I'm sure there's one that I've missed. Apologies in advance. But the ones that I'm aware of is glycine for your NSK, obviously, erythritol for your EMS, Trehalose for the Luno system. I've never actually used the Luno system, but I've heard it's very messy. But I'll be keen to try it out. And then you've got Tagatose from BA International as well, which are all very, very safe to use on composites and subgingivally. So please make sure, because you know, we're sometimes very, very busy, but make sure your nurses have got the right powders set up in your airfoil polishing unit before you start spraying these composites. Otherwise, you are going to start damaging them. So as we were talking about earlier, it's really important to have an understanding of where the water and the powder meets, to how far away you're going to distance the air polishing unit from the tooth or the composite. So I always say 4. I mean, I use the NSK, I use it at about 3 to 5 millimeters is a sweet spot. EMS, as far as I know, used to be around 4 millimeters away from the tooth surface. Now there's some studies coming out from EMS saying that they want it as close to the tooth surface as possible. The point being, every system is different. So please check with your rep, get in contact with them, whatever system you have, they're really, really good. Check the correct way to use them. Because when we're removing stain on enamel, enamel's the hardest substance in our body. We're not too concerned. We could use abrasive powders. We could keep it away from the gingiva, and we know we're not going to cause much harm. But when we're polishing these teeth, you want to make sure that you're getting the full effectiveness out of it without harming these composites. So contact your reps, find out all the different types of powders they offer and the best way to use them, how to angle them, and how far away from the tooth surface to position them. What does the evidence say? Well, the evidence tells us that all surfaces of a restoration must be maintained and polished to reduce plaque stagnation. That's obvious. The extent of surface composite and surface damage is material dependent. Sodium bicarbonate has a strong detrimental effect on composite surfaces than glycine or erythritol. There is no advantage over erythritol or glycine. If we look at the studies, they're both very similar particle sizes. They both work great. And the lowest roughening of the composite surfaces tested was obtained by air polishing with glycine for 5 seconds. So loads of studies out there. on different air polishing units. They all have their advantages, but the key thing is to ensure that you're using them correctly. And if you're unsure, just ask. Thank you very much. I think I did pretty well for time in there. So sorry if I overran, Lauren. But please scan this QR code. Thank you so much for spending this evening with me. Please scan this QR code in order for us to be able to get the CPD sorted for you. And also a massive thank you to NSK Ikigai for having me on tonight. Please follow us on Facebook and Instagram. We'll try and get through as many questions as we can. Hopefully I could answer them. But if you have any further questions and you want to reach out, please feel free to reach out anytime. Thank you.
Perfect. I'm just going to pop the link to that as well into the chat so that you can fill it out if you can't scan the QR code. Let me just pop that in just now. So we do have a few questions, but keep popping them into the Q&A box ideally if you can. We have got one that was in the chat. Let me see. So I think this was actually put in quite early on, so you might have answered this already. But so with the regular hygienist appointments, is there anything that you'd be telling a hygienist, such as avoiding prophy paste or using the ultrasonic on a lower setting?
Yeah, I mean, I think with composites, you should always be a little bit more careful, but at the same time, with the prophy paste, you want to make sure that you're using something that is not too coarse, essentially, and check with the manufacturers depending on the course. With the ultrasonic side of things, I'd avoid using the ultrasonic on the surface of the composite. But if it's on a very low setting, it's absolutely fine. But most of the time, we're going around the gingival margins. So I would just tell my colleagues that are treating any of my cases to just use it as normal. And if there are chips and breakages from an ultrasonic that is used correctly with the correct tips and the correct technique, then I think that's something to do with my bonding. So I'll have to take a good long look at myself.
Yeah, I think we always say, don't we, if it's come off during a hygiene appointment, it was coming off anyway, right? So
exactly.
there's something wrong. So someone else is saying, fab presentation tips, first of all. Can you describe how you would repair a part-filled composite?
Yeah, so completely depends. If it's a area where it's for functional reasons, we'll need to assess whether it's the benefits of using removing the whole restoration or just repairing it. If we're assuming that we're just repairing it, I tend to sandblast the composite with aluminium oxide, 27 microns. So if you use the 50 microns aluminium oxide in a sandblaster, that tends to actually cut away a composite, and it could harm dentine as well. So you want to stick to the 27 microns, and that opens the pores up of the composite. So I would, if it's a composite veneer, for example, I would bevel the veneer slightly. Most of the time I'll try to remove it unless I don't have the time. But if I bevel it, I'll then use the sandblaster to get that really nice dry porous effect of the composite with the aluminium oxide. Then I use something called silane, which is what is used to cement sort of porcelain work. It comes in 2 little bottles, and this is what evidence is telling us this is the best way to repair composite onto composite. So obviously, if we're just repairing back onto enamel, we follow our normal etch bond protocols. If we're bonding onto composite, sandblast composite with aluminium oxide, 1 drop of silane into a dappen spot. It comes with an A and a B, micro brush, dry very gently with 3-in-1 tip, and then place the composite on top, and then light cure. And that will give you a good bond, and then polish everything in to make it look pretty.
Perfect, thank you. Someone else is asking, do you need to use an oil-free compressor with the NSK Various Combi Pro? The answer to that is yes, it needs to be oil-free. I would suggest that if you are purchasing one, you'll get support from your local rep anyway. So just consult them, and they will sort that out for you, and they'll check that your compressor is the right type and everything as well. All right, so hopefully that helps. I've got another question about repairing composite fractures, but you've just answered that.
Okay.
Someone else is asking, are there any NSK discounts available? If you look in the chat box, I've just put a discount code in there for the NSK web shop. That will get you 40% off anything on the web shop, whether it's air polishers, handpiece, ultrasonic units, whatever, 40% off until the 22nd of May. And I'll just read that code just in case you can't see it or something. Let me see. So it's WIN0525. And if you scroll up the chat a little bit, you should be able to see that. All right. Someone else is asking, with edge bonding, I can polish up the composite, but how do you polish the tooth enamel part to make it lustrous?
So what you want to do, I think, I'm presuming you're talking about the margin between the composite and the enamel. So you don't want to polish the enamel away. That's the first thing. So when you're using your composite, the best way to do it is when you're placing your composites. I'm a big fan of the Optra pads and some wetting resin. That way, I always try to extend a very thin layer of composite higher up to the edge bonding. So my edge bonding is actually not on the edge. My composites go about 50% above the tooth, but it's just a very thin layer. And with that wetting resin and that pressure I apply to spread that composite along the top of the tooth, I get a really nice flat surface. There will still be a margin. I then get my coarse soft flex disc, not the most coarse one, the one down from that. And I like to use the large ones like you saw in my videos because you get a bit of a flex when you apply some pressure. When you use the smaller ones, sometimes the middle touches the composite, it scratches it, it all becomes a bit of a headache. So I like to use larger ones because you can apply a bit of pressure and you want to polish from the composite onto the enamel surface. So you want to apply a tiny bit of pressure so the soft flex disc just flexes a little bit and polish down slightly, following your anatomy lines, but never polish over those, but just follow those lines and polish down slightly from composite to tooth, always composite to tooth. If you go from tooth to composite, you're going to be polishing away enamel. So you want to go from composite to tooth.
Perfect. Someone else is asking about interproximal stains. What would you use for an interproximal stain?
So interproximal stains, first and foremost, assess to see if there's any chips and breakages on the interproximal side of things. I always, first thing first, I always try to get rid of it with my air polishing. So composite safe powders, glycine works pretty well for me, and see how much I could remove that way. If not, I then move on to my polishing burrs, and the wheels work really well on that part as well because they kind of just go into that space really nicely, and I'll try to buffer them up that way. And if I still don't get nowhere, I use a very, very fine interproximal strip, and it takes a long time, and patients don't appreciate it because you're using an interproximal strip and their head's nodding up and down while you're doing it. But that tends to work very well for me.
Perfect. Someone is saying a few people I think are having difficulty with the CPD link. I have just clicked it and it did load. I'm on a PC though, so maybe it could be a phone issue. Maybe if you're on a phone, don't worry. In any case, like I think we mentioned at the start, just in case anyone wasn't here, if you're having difficulty and you can't get it to work, I would suggest just taking a screenshot of this slide just so you can try again a little bit later. If you can't do that, when it is added onto the webinar archive in around about 7 days, you'll be able to log on and get your CPT certificate then. All right, because it's just a test. I said at the start, we're testing this new system so that we can do it instantly, hopefully. And I think a few people have managed, so we will see how that goes. Someone else is asking, how do you make corrections at the gingival margin to remove overhangs and improve periodontal health?
Good question. So completely depends. I tend to use a number of things. My go-to is I will try get an image of it if I can, but my go-to is what we call a shofu burr. So it's a very thin, goes onto a fast handpiece, and it's got a yellow band on the edge. But when you look at the tip, it almost looks a bit like carbon. It's quite grey. It doesn't have diamonds. It doesn't have anything like that. And it's a very thin point. And I very gently run over the margin and try to eliminate that overhang with that if it's composite material. Because with amalgams, that's not going to do anything. But with composites, that's what I will try to do. If it's overhangs that I'm creating while I'm placing, I tend to just flick them off with flat plastic, or a scalpel 12 blades sometimes to get in there. They're really good to cut away some composite, etc. But be careful with the gingiva, obviously. But I use those. There's also a really nice diamond, blue diamond. I'll try get a list of these. I don't know, Lauren, if we can maybe get a list of a few of the burrs, and
Yeah,
I can maybe send it to a few of the guys.
perfect.
There's a really nice one that goes onto a slow handpiece. Again, tapered diamond burr. That's really nice to polish, and you won't be removing any enamel or doing any harm to the enamel, which gives you a bit more confidence to go into the margins and eliminate any overhangs there. But yeah, just take your time. There's no easy way of doing it, unfortunately. But just take your time and try to take back that composite about 1 millimeter away from the gingiva will be my advice.
Great. So someone else is saying, hi, Ibby, great webinar. Are the NSK peak ultrasonic tips suitable for use around composites where there's light calculus? I mean the ones which are used around the implant body.
Yeah. Yeah. Like I said, I use my ultrasonic around all my composites. I try to avoid the surface of the composite, but just around the gingival margin, I use my composites. Any calculus, absolutely fine to dislodge with an ultrasonic scaler.
Yeah. I think the only thing about the peak ones sometimes is they're a little bit bulkier, so sometimes it can be quite hard to get in if you're trying to get in around margins and things.
Yeah.
So your kind of standard ultrasonic tip on a nice low setting is
Absolutely
fine to me
yeah.
anyway.
Keep it nice and simple.
Do you use loads of questions? Do you use retraction cord to place your composite?
No. So it depends how I'm placing my composite. If I'm doing my freehand cases, sometimes I do. But because I'm going 1 millimeter away from the gums and I'm very particular with my patient's oral hygiene, I tend to not use retraction cord. Sometimes I may, but it's very rarely done. And then if I'm doing a digital workflow where I'm doing injectable composites, I just ask them to make the stent 1 millimeter below the gingiva for me, the gingival margin, and there's no need for retraction cord there. I know some people roll up PTFE and get it in there as well, but I've heard some horror stories of it getting lost in there and all sorts. So it's completely up to you. You can use retraction cord. It's great practice to use retraction cord, especially if you're worried that you're going to get a little bit of bleeding around that area. Then definitely use some retraction cord with some astringent to just keep everything tucked away.
Great. Someone else is asking, can you go over what you mean by final cure with glycerin, please?
Yes, so once you placed your composite, you should use some glycerin in a syringe, which could also be found at your local pharmacy as KY jelly. Very cheap, very cheerful way of purchasing it. You do not need to buy the fancy composite glycine ones, which cost quite a bit from dental companies. You can keep it very simple. You basically just smear the glycine over the composite that you've just placed and do another light cure. And that allows the composite to fully set and for it not to be so porous as well. So yeah, definitely it's so important when you're doing composite work, especially if you're doing anterior work. You should do it on all your composites, but very important for your anterior work.
Great. So which composite do you tend to use for anteriors, and can you recommend any hands-on courses that you've done?
Yes and yes. So composite wise depends again. So where we were talking about the different types of composites, if I'm very concerned about my patient's occlusion, even though we're correcting it, I'm still unsure, I will go for a venous pearl, but I would always book longer for my polishing appointment, because to get that venous pearl to really shine and pop, it takes a little bit of patience with your polishing. Same steps we discussed, but it just takes a little bit of time. But most of the time I like to use Ivoclar Empress for most of my smile makeovers, or edge bonding. Gives a really nice shine, a little bit more prone to chipping in my experience, but overall pretty good composite and holds out just well if you're okay with your occlusion. Courses, honestly, I mean, Lauren knows me well. We've done a lot of courses together, Lauren, as well. But there's so many composite courses out there. My advice for you is to do as many as you can, because you will learn something new from every single one. There's great courses out there. If you want to start off and you're just starting into it, you could look at the Restore course. Then you can move on and go into a little bit more of the advanced stuff. If you want to start looking at smile makeovers, I'll advise that you start with the digital side before you go into freehand. So Avant-Garde is a great option. And Emily, the dental therapist that runs the course there, is absolutely brilliant. Some of the work she does is phenomenal. So I really recommend that if you're looking at those side of things. But my advice will be start off with the basics, go for your basic anterior, posterior composite courses. They're all amazing, guys. I've done all of them. I've done Monique's, I've done Smile Academy. I've done so many different courses out there. They're all great. You'll pick up a nugget from every single one that will mold you into your own clinician. So, yeah.
Yeah, I think it's just kind of realizing that not, somebody might say they love one course, but it's about finding out what fits in with your goals and aims and what you want to be doing, right? So I think it's just looking into lots and seeing what suits you,
Exactly that.
really. Someone is saying, if you are disking and polishing and you've removed the secondary anatomy and the tooth appears flat, how can you recreate the secondary anatomy and line angles?
Well, the line angles, you might be able to polish back in and recreate them with a coarse soft like this, but that means that you're going to be polishing out more composite. So the honest answer is, if you've eliminated secondary anatomy, it's very difficult for you to get it back. And I would not advise you to pick up burrs and start trying to create them again. I would probably cut back the composite and start all over again. And that is my advice. I'm not saying that's the right way to go about it, but I'm definitely not confident enough to pick up a handpiece and implement anatomy into there. Your line angles, you might be able to polish into it depending on how much composite you have. So grab a pencil, draw where you want your line angles, and then polish everywhere apart from where your pencil lines are. So the sides of the teeth, the front of the tooth, and implement your new line angles, and you can move them side to side depending on where your pencil marks are. But always grab a pencil and draw onto the composite. That really helps, makes such a big difference.
Can tooth whitening improve jaded composite?
So I mean, the answer is no, but I've seen it work. So it will remove some superficial stain, but then you could also do that with a hygiene maintenance appointment. But I remember I had a patient actually that came in and had really nice composites, but they were really badly stained, and they said, I just want to do whitening. So I got the dentist involved, and we said, well, I don't think whitening is going to really help. They're like, no, I know my teeth, please. I just want to do some whitening. I know that these stains will come away. And we were both very surprised at how much stain was removed from these composites from them using the whitening gels. But it did work. So the answer is yes, whitening can improve the appearance of composites, but it's not going to whiten the composite. It will only remove any superficial stain. So the best thing to do is maintenance. And if you are going to do whitening, you want to whiten teeth, not composites.
What if the composite appears splodgy or mottled in color? Would you resurface with a new layer of composite?
So yeah, you would have to consider how much composite you're adding on. If it's mottled in color and it's giving that appearance, then the best thing to do is find out why that's the case. So has it been repaired numerous amount of times? Is that what's happened before? Have people constantly been adding on more composite in different little patches, and hence why they're all staining at a different rate, and loads of different margins, etc. So I would probably advise the patient that let's polish this back. Let's see how much of it we're going to remove, how much is left, and then decide whether we need to replace the whole thing. But it all depends on the depth of it. Start off with a very light soft flex and see if you could blend it in. Grab a straight probe, see if you could detect any margins on the composites, and then gently polish it in to see if that alleviates it. And if you feel like you're not getting anywhere, then it's probably time Don't forget to ask some really obvious questions in your history. How long have you had the composites for? If the patient says, I've had my composites for 10 years, it's probably time they get some new ones. You know, you're expecting a good, well-maintained composite material with a patient that looks after it really well. You'd expect it to have that nice shine and still look really good for about 5 years or so. I know some people say 7, but I think they still look a bit matte and it's very difficult to spruce them up again. So about 5 to 7 years is what you're looking at. So it depends on a load of factors really, but ask the questions, find out how long they've been there, cut back as much as you can.
Do you recommend the goat hair wheels for polishing? Do you use those?
I've not actually used those before, but I've heard good things. One of my colleagues at work uses them. I've never used them, so unfortunately I can't comment on them, but I could say that I've heard good things. Like I was saying earlier, if it's something that you're comfortable with and you know how to use, then go for it. If you're lucky enough like me, where you've got loads of nurses and you can just practice on them, then go for it.
I think what we always say as well is sometimes you'll find that the therapist surgery has not got some of the nice things that's in some of the other surgeries. So go around the practice, ask everyone else what they use, try and nab one of each thing and have a little practice, as you say, get a willing volunteer and just go for it and see how it comes out. Someone else is wanted to know which camera you use and which loops you use as well.
So I use Bryant dental loops, always have. I found them great. I'm on a 3.8 mag, I think, at the moment. But I'm looking to upgrade to a 5 mag when my wife says I'm allowed to spend some money again. And in terms of dental camera, I've got a pretty straightforward setup. It's a Canon 60D with a macro lens. And my flash is not a very expensive one either. I got it from Amazon. It's Yongnuo, I think it's called. It's a twin flash. It ranges from about 90 to 120 pound because my wife wouldn't let me spend 900 pound on a Canon flash.
I didn't let myself spend 900 pounds on one either. I've got the same one. If a patient came in with old 10+ years composites with small chips, would you repair on the NHS or only offer private?
So I don't work in the NHS and I never have. So I can't really comment on that side of things. But it depends on the patient's concerns, how they've chipped up. There's so many factors here. How they've chipped it. Is it causing them sensitivity? Is it causing them discomfort? Is it a functional fill-in? Was it a fracture repair? Is it a cosmetic fill-in? I mean, there's loads to consider here. But my advice will be discuss with your principal dentist. If you're doing anything on the NHS, make sure that you're following all correct guidelines. And if you're unsure, just discuss with your principal. Would be my advice. I can't really advise you on the best way to move forward with that. But a 10-year-old composite that's chipped, if you're just going to repair it, it might be worth just changing the whole thing over, to be honest. But discussing the risks and the benefits with the patients in detail first, of course.
Okay, we've still got some more. Is warmed up water better than cold water to remove stains?
Makes no difference whatsoever. The temperature of the water has no influence on how much stain you're going to remove. It just makes it a nice, pleasant experience for the patient, unless it's a really hot day, I guess. But yeah, it makes no difference. It's all to do with the powder and the type of powder you're using and the distance and the angle that you're holding your airflow from to ensure that the powder meets the water at that right point to get that reaction.
Okay, we will have one last one. Let me see. So how much roughly, what's your kind of price range for composites and repairs? Someone is asking.
So again, completely depends. Sorry, excuse me. So composite veneers, I charge starting from £350 for composite veneers. Composite edge bonding, again, case dependent, how many teeth you're doing, how much time it's going to take you, patient's expectations. Always remember to value your time and respect the practice's time as well, because it does cost the surgery when you're in there for a long time. So I start my composite edge bondings from around 175 for cosmetic reasons. Repairs, I give all my patients a 2-year guarantee with their composites, because if I've this is just a personal preference, but if I've gone through all that effort and I'm confident that the patient is looking after their teeth really well, and my composites don't last for 2 years, then I feel like I'm not really doing that patient justice. They've invested so much money for a smile makeover. But then if I think that patient is constantly breaking their teeth because they're not following my instructions and they're cracking beer bottles, then I will charge them for the repair accordingly, and that will be judged on my clinical time. So if the repair is going to take me 30 minutes, I'll do it off roughly what my clinical surgery time will cost. If you don't know this, these are conversations you should have with your principal dentist and your practice managers, roughly off what that will cost, and just to cover the materials as well. So anything ranging from 80 to 150 pound, depending on the significance of the chip.
Brilliant. I think that is us. I think everyone's still here as well. So
Amazing.
thank you all for coming. If you haven't managed to access the CPD feedback form, just a little reminder, you can do that when this webinar goes online on the My NSK Ikigai website in 7 days or so time. If you just give us at least 7 days just to get it up, it might be a little bit sooner, but allow 7 days, please. Just lots of people, Ibs, just saying thank you for a great webinar. Lovely webinar, great presentation. So thank you very much for speaking to us all this evening. And I'm sure we'll have you back again.
Thank you very much. It'll be an absolute pleasure. Thank you all for spending this evening.
Thank you. Have a lovely evening, everyone.
Take care, everyone. Bye-bye.
Bye.